Hello, my name is Dr. Lynn Kobeissi. I'm a postdoctoral research fellow here at the Division of Gastroenterology at Johns Hopkins. I'm here to discuss an important topic that we've worked on with some of my colleagues here at the division about the management of patients with inflammatory bowel diseases, or IBD. Specifically, what to do when patients do not respond to upadacitinib. Upadacitinib is a selective JAK1 inhibitor that's been a game changer for patients who have been previously treated with an anti-TNF agent. Clinical trials have shown remission rates approaching 50%, and in real-world practice, this number can go as high as 80%. Despite these promising results, not all patients achieve clinical and endoscopic remission. So, how should we manage patients who either fail or are intolerant to upadacitinib? We undertook recently a retrospective cohort study at Johns Hopkins Medicine, which explored this question in depth. We looked at 135 patients with Crohn's disease, ulcerative colitis, or indeterminate colitis, who were treated with upadacitinib between January 2020 and September 2024. Out of these 135 patients, 42 did not achieve clinical response. All of them had prior anti-TNF exposure, and most were maintained on a 30 mg daily dose. Interestingly, 5 patients were reinduced with 45 mg daily, and 4 of them showed clinical improvement. This suggests that reinduction can be an effective strategy, especially for patients who showed initial improvement but then relapsed. In addition to reinduction, combination therapy also showed promise. 4 patients who remained on upadacitinib despite inadequate response had risankizumab added to their regimen, and all showed improved clinical response. This highlights the potential benefit of combination therapy in managing refractory cases. For those who discontinued upadacitinib, switching to another agent was the next step. 22 patients were switched, with risankizumab being the most commonly used alternative. Notably, half of these patients showed clinical improvement within 3 months. What does this mean for our clinical practice? It suggests that reinduction at a higher dose, combination therapy, or switching to another agent are all viable strategies when managing patients with inadequate response or intolerance to upadacitinib. Importantly, these strategies could help us avoid surgical interventions and improve overall disease management. As we continue to gather real-world data, it's clear that personalized treatment approaches are essential in IBD management. By staying flexible and considering multiple therapeutic options, we can better address the needs of our patients. Thank you for watching. If you found this discussion helpful, feel free to share it with your colleagues and stay tuned for more insights on managing complex IBD cases.